Will kind of mentioned Will kind of mentioned that we're doing these trainings in sessions of 4. And again, we're trying to train on like substance use disorder, and obviously opiate use disorder is a big part of that in the kind of current culture that we swim in. And so I'm going to run through a BUP 101. I did this training a few months ago, but we do want to sort of like make this continually available to people because because of the need of treating patients with opiate use disorder and just how helpful buprenorphine can be. And so I'm going to try to run through this kind of quickly today, maybe hopefully within like 30 minutes. I do have a case study we can go over, but also have space for you guys to ask questions, or like Will said, do any other cases that you guys want to talk about today. So if this is review for you, I always say repetition breeds comprehension, but if it's new for you, I think it could be really helpful. So just a quick backstory. So when I learned how to treat patients with substance use disorder, I got taught by a couple of ER doctors, and they were seeing patients in the ER who were coming in with sort of like drug-seeking behavior, not exactly knowing like, how do I help these people long term, because they would continue to come in with different pain issues. And so one of the ER docs at that time was doing some continuing education, maybe similar to what you're doing today, continuing education to be able to meet the requirements for the DEA, or to get your renewal. And anyway, so he did this X waiver training where he did all these hours. It was like 18 or 20 hours of education, got the X waiver back then to be able to prescribe buprenorphine, and didn't really do anything with it initially until one of the DEA agents showed up in the ER asking him about this X waiver. And so whenever the DEA agent shows up in your office or ER, you get a little nervous. And he was like, hey, I haven't done anything with this X waiver. I haven't prescribed buprenorphine yet. And so I haven't done anything wrong, essentially. And the DEA agent looked at him and said, hey, you need to be prescribing this medication because it actually saves people's lives. And so that was such a mismatch experience for him that him and his buddy kind of got looking into like, hey, what is this medication? How do we use it? How do we help people? And so they started treating people. And that was a little over 10 years ago. And so I've been working alongside of them for just about 5 years. And so my whole point in telling you that whole story is just to say, hey, buprenorphine is a safe medication that can really be helpful for the right patient population. And so my whole goal in going over this today is to help you understand the medication and really encourage you to prescribe it. And like Will said, we're available to you if you have questions about starting patients on Suboxone or buprenorphine. So along those lines, December of last year, there was this, you used to have an X waiver to prescribe Suboxone, but there was this Consolidated Appropriations Act where essentially it was just like the X waiver got rid of that. There was a new requirement of 8 hours of training, and that sort of fully went into effect last year in June, where prescribers need to complete 8 hours of continuing education on the treatment or management, specifically of opiate use disorder or other substance use disorders. And so obviously this training today qualifies for that. These are the learning objectives. I'm not going to stop and really talk through those, but if you want to read those, you can. The agenda today, again, want to talk about the different options for opiate use disorder, talk quickly about buprenorphine, how a medicine works, how to take the medicine correctly. I really want to try to hammer down precipitated withdrawals and what that is. And then we'll talk about some side effects, interactions, special populations, and then we'll go over some case studies here at the end of our time. All right, so options for medications for opiate use disorder. So currently there are 3 FDA-approved medications for opiate use disorder. Methadone is the initial medication that has been around for a really long time. It has helped a lot of people. It used to be the gold standard in treatment for opiate use disorder. And essentially the way the methadone works, which is helpful to understand, is in this picture right here. But methadone rests on that opiate receptor, and it fully turns that receptor on. So the full opiate effect essentially can get higher levels of dopamine, helps with pain. Sometimes it can relate in euphoria or over sedation, but that's sort of how the methadone works. Buprenorphine, in contrast, or Suboxone, when I say buprenorphine, referring to the Suboxone, but the active ingredient, essentially is a partial agonist. So it sits on that receptor in a partial way. Instead of turning that receptor on at 100%, like methadone does, or fentanyl, or heroin, or oxycodone, it turns it on at like 50%. So there's only a partial activation. I'd say maybe closer probably to 30 or 40%. And then the naltrexone is another option. Essentially, the way that medication works is it's an opiate blocker. So it sits on that opiate receptor, blocks it, so other opiates cannot get onto that receptor. Um, Naltrexone really is not first line, in my opinion, for opiate use disorder. The concern with the naltrexone is that if a patient gets on naltrexone for a period of time, their tolerance for opiates goes down so much, and there's not great compliance with the medication. So let's say a patient gets in a situation where they've used substances before, they may stop their naltrexone and go back to substance use. And if that's the case, specifically with opiates and the fentanyls that are out there right now, there is a high risk of overdose in that situation. So it is an FDA approved medication in the right place. It can be helpful, but I do have some concerns with it from that standpoint. Again, this slide deck will be available to you if you want to look at it again, but here's just a chart. What we're looking at here is, methadone versus buprenorphine versus naltrexone. We just talked through the mechanism of action, again, what the medications do, suppress withdrawal symptoms, and they help with cravings. There's essentially some more drug-drug interactions with methadone, fewer with buprenorphine. Again, the naltrexone is contradicted with patients that have an opiate use disorder who are actively using opiates. We'll talk kind of more about that later on. As far as like pregnancy, breastfeeding, both of these are first line. Naltrexone, not so much. There's not enough evidence to confirm if it's safe in pregnancy or breastfeeding at this point. Another little chart here for you, sort of advantages, disadvantages. Again, one of the advantages of methadone, it can achieve a higher opiate receptor activation. Also, there's not a risk for precipitated withdrawals, which we're going to go into a lot more detail here in a few minutes. So this is one of the advantages of the methadone. Disadvantages, there is probably a higher abuse potential, maybe not quite as safe. There are some significant drug-drug interactions. Have this all the way down on the slide here, but it does require sort of daily observed dispensing at a outpatient place. And so sometimes you'll get some take homes with the methadone, but it's a lot more labor intensive for the patients to do methadone. Again, buprenorphine, I'm trying to sell you on buprenorphine, but decreased abuse potential, more favorable safety profile. It does have this blocking component, which we'll talk more about. Less drug-drug interactions, but again, disadvantages. Patients starting on Suboxone can have a hard time due to the precipitated withdrawals. It does create a physical dependence, so patients are dependent on buprenorphine in the same way as methadone. There is some concern for diversion with these medications as well, so just some of the honest disadvantages. Naltrexone advantages, no dependence, little abuse, no significant drug-drug interactions. It does come in an oral and IM form. Just highlighting here, it does take 7 to 10 days of no opiates before someone starts on naltrexone. I did have a patient that I started on oral naltrexone for opiate use disorder. She was close to like the 7-day mark and took the medication and did actually throw herself into some precipitated withdrawals. So just to be mindful, I always push maybe towards the 10 to maybe even 14 days from last opiate use. And again, just at the bottom here, highlighting risk of fatal overdose after discontinuing the treatment. All right, so a quick knowledge check on the initial stuff. The question is, what pharmacological properties of buprenorphine makes it preferable to methadone for the treatment in the outpatient setting? And again, the way I would answer that is that buprenorphine is a partial opiate receptor. Methadone is a full opiate receptor. And again, it has decreased abuse potential, improved safety profile, fewer drug-drug interactions, and it does protect the opiate blockade at the mu receptor, which we'll go over here in a second. All right, so a couple of just kind of quick fast facts about buprenorphine. So again, FDA-approved medication for opiate use disorder and chronic severe pain. For opiate use disorder specifically, here's the the medications are the formulations. So the mono product, which is just buprenorphine without the naloxone, comes in a generic form, or Subutex, also in the injectable Sublocade form. Buprenorphine naloxone, which is the combo product, generally referred to as Suboxone, does have a generic form. It also comes in a Zubsolv as well, which is just a different manufacturer. And then currently the chronic pain, severe pain indications is the Belbuca and the Butrans patches. Again, I just have another little chart here that sort of shows you the different dosing of that. So buprenorphine or Suboxone comes in at 2, 4, 8, and 12. The tablet only comes in 2 and 8 milligrams. Here's the Suboxone. I guess that's the generic. Here's the Suboxone. Zubsolv's dosing is a little different. And then here's the Subutex formulations there. So talking about how to take the medication, I'll go into this in more detail in a few minutes as well. But again, Suboxone is a little bit of a difficult medication to take. You have to put it underneath your tongue. You need to allow it to dissolve, hold it in your mouth for 10 to 15 minutes without kind of talking or swallowing. And the reason that the medication is taken that way is just related to bioavailability. So if you swallow Suboxone, less than 10% gets absorbed systemically. When you take it underneath the tongue, we're looking at closer to 30 to 35%. And if somebody had a history of IV drug use and tried to inject the medication, 100% of that becomes added. So when we talk about Suboxone, we need to talk about the difference between the naltrexone and the naloxone that's in the Suboxone. So again, this was really hard for me when I first started because these two names of these medications were so close together. It took me a while to wrap my head around this. But essentially, the naltrexone is also known as the Vivitrol in the injectable form, but it's a long-acting opiate receptor antagonist. Again, mainly for opiate use disorder and for alcohol use disorder is primarily what we use it for. Again, PO and IM. The naloxone is, I try to think of it as Narcan. And again, with Suboxone, we have the buprenorphine with the naloxone. Again, it's a short-acting opiate antagonist. We use Narcan for overdose reversal agent. It comes in the nasal spray, which most people are familiar with, and then the IM and the IV forms of that as well. So the question you should be asking is, why is naloxone added to this? And the main reason that naloxone is added to the Suboxone combination is to prevent abuse of the medication through IV injection or through nasal inhalation. So again, when you look at the naloxone bioavailability, if you take it orally, it doesn't show up very much in your system. Sublingually, also less than 5%. But if you would choose to snort it or inject it, it becomes much more available. Now, I've talked to multiple patients who have injected Suboxone, and in theory, this does prevent people from abusing the medication, and I think it is a really helpful deterrent, but you're not going to be able to stop every person that wants to abuse a medication or substance, because sometimes the short-acting nature of the naloxone goes away after a little bit, and then the buprenorphine, that's a long-acting medication, is more bioavailable. So again, I just point that out just to say, like, hey, that's the reason it's in there. Some people still try to abuse it, but most of the time it's not abused as much. So which type of medication should you prescribe to any individual patient? Well, I would just say the majority of opiate use disorder patients are going to do, at least what I use, is the buprenorphine naloxone combo product. Generally lower cost on most Medicaid formularies, lower risk of diversion. Some patients will have side effects with Suboxone, either headaches, nausea, vomiting, pretty common, sometimes peripheral edema. In those cases, a lot of times maybe we'll try switching them to the Zubsolv or even the Sublocade, which is the injectable form of the medication. Obviously, if somebody has a type 1 reaction to the buprenorphine Suboxone combination, again, the naloxone, it does get absorbed in some ways, but it doesn't cross the blood-brain barrier. So there are patients that do have allergic reactions, kind of just more to the naloxone or don't tolerate it. And so in those patients, we will use the Subutex or the Sublocade. And then in pregnant patients, currently combo and mono product is what we recommend. I do think that always have patients check with their OBGYN, but I do offer patients to switch over to the mono product if they would like to do that. So again, who can take, Suboxone or buprenorphine and who cannot. We talk about the DSM-5 criteria for opiate use disorder. So any patient that qualifies for that, and pregnant patients, adolescents, as long as they're old enough in the state where you're treating them, if anybody has a history of opiate use disorder, physical dependence on opiates, or they've been abstinent for a period of time and there's a risk for return to use. So most often I see those patients coming out of incarceration where they've had a period of time of not using, months to years, and then they're getting back out into society and they're having significant cravings, desire to use. You can use Suboxone in those patients as well. Again, if they have a hypersensitivity to the medication, you wouldn't want to give it to them, or if they're on naltrexone or Vivitrol. Um, I did include this slide here. This is just DSM-5 questions. This is like a patient-facing form of the question. So I know it's like pretty small and hard to read, but essentially the questions are just like, have you been using opiates for longer than was intended? Have you had a desire to cut back on it? Do you spend a lot of time getting the medications? Do you have cravings? Has it gotten in the way of major obligations at work? Are you having social, interpersonal problems? Have you had to give up social activities? And then kind of gets into more of like, have you developed a tolerance to it? Or do you get withdrawals when you stop using it? And so again, you only have to have like 2 or 3 positive answers on this to actually diagnose someone with a mild substance use disorder. But most patients that are coming for help with opiate use disorder or other substance use disorder are going to answer yes to almost all of those questions. Okay, so we diagnose someone with opiate use disorder, we get them on Suboxone. How long do we have these patients on this medication? So again, I really like to drive home the fact, or at least what we believe about substance use disorder and opiate use disorder, that this is a chronic long-term disease process. And so when we think of other chronic disease processes, diabetes, hypertension, mental health things, depression, things like that, a lot of times patients are on a medication for a long time, maybe even for the rest of their life. So I always tell patients, hey, at least 6 to 12 months of stability on the medication where you're feeling well, you're getting your life back in order, you're not using any other substances. Again, here's some recommendations from ASAM that just says, longer is better. They recommend indefinite treatment with buprenorphine is recommended unless the patient is having harms from it, or unless they make a self-informed decision to taper off the medication. I won't go a lot into tapering off the medications. A lot of times patients will just start taking less over a period of time. But one thing that has been new recently is we've had a lot of success with patients tapering off of buprenorphine using the Sublocade injection. And so if they've been on Suboxone for a period of time, we'll give them 1 or 2 or 3 injections of Sublocade. And as that Sublocade slowly leaves their system over the course of several months, they get less withdrawals and they seem to do really well coming off the medication. So a little bit newer thing that we've been doing in the last maybe 2 or 3 months, but we've had a lot of recommending more frequently, but would have had a lot of success over the last years of seeing patients do well on that. All right, little knowledge check for you. Why is combination preferred over the mono product? And again, it includes the naloxone, which we went over, deters the use of IV injection or nasal inhalation, so decreased risk of diversion of the medication. Checking where I'm at in my slides and how much time I got. All right, let's talk about how the medication actually works. So mechanism of action, it's a partial opiate receptor. I kind of mentioned that already. It sits on that opiate receptor in a partial way, turns it on to about 40%, where methadone would turn it on to 100%. So would fentanyl, oxycodone, things like that. One thing I really want you to understand is the ceiling effect of buprenorphine. So because buprenorphine sits tightly on the opiate receptor, more tightly than other opiates like fentanyl or methadone, it has this blocking effect, and it also has a ceiling effect. And so what the ceiling effect is you only have so many opiate receptors in your brain that are available to get the medication on board. And so when you have saturated those all or most of those, essentially all of those are only turned on at 40%, where if in an overdose case, all of those are turned on more at like 100%. And so the ceiling effect makes the medication really, really safe to prescribe in an outpatient setting. And so here's another chart that just sort of reiterates what I'm saying. So as the dose of a full agonist increases here on the bottom line, again, heroin, fentanyl, oxycodone, eventually the levels go up and up and up where you cross this threshold for overdose. But with buprenorphine or Suboxone, you can increase that dose as much as you want, and we're going to hit this ceiling where it just doesn't go any higher because there's just not any more opiate receptors available. So, um, again, as you're prescribing the medication, I want people to know this and understand it because it really helps encourage you to feel safe about prescribing it because patients can literally take, if the maximum dose is supposed to be 24 milligrams, they could take twice that much amount of Suboxone or even more. Or even if they injected the medication, they're going to get to a threshold where they're not going to get any more dopamine relief. And so the ceiling effect is really kind of a cool part of how the medication works. Okay, so true or false? Ceiling effect of buprenorphine, even at high doses, reduces the risk of respiratory depression relative to full opiate. Um, and obviously, that's true. We kind of just went over that. All right, let's talk quickly, well, for a few minutes here about how to take the medication. So buprenorphine is recommended to be taken once a day. It has a long half-life of 24 to 42 hours. Generally, I see patients feeling like the medicine stays in their system for about 3 days. It sort of has an onset 30 to 60 minutes. You'll see a peak 1 to 4 hours after they take the medication, and then the medicine levels will kind of start going down. It is it comes in like an 8 milligram or 2 milligram, but it is okay to have the patients cut those into smaller pieces, whether they use a pill cutter or scissors. I really feel like absorption of Suboxone is really dependent on the dosing technique. Um, there's just so much about the oral absorption in the mouth that really affects the patient's levels of the medication. So when would you consider not doing once a day dosing? Sometimes late in pregnancy, patients will split the dose twice a day, feel like they get a little bit better coverage. A lot of times for short-term acute or post-op pain management, I will recommend that patients split their dose either twice a day, 3 times a day, or up to 4 times a day. The analgesic effects of buprenorphine can last like 6 to 8 hours. So another reason to split that. It's totally reasonable too if you have a patient maintained on Suboxone, let's say 8 milligrams or whatever. If they're going to have a dental procedure or outpatient procedure to sort of increase that dose and split it up for a week or so, a lot of times patients will get really good pain control that way. As far as patient preference, I see a lot of patients that prefer twice a day dosing. They feel like the medicine lasts longer. It's just maybe more in the rhythm of what they've been doing. So if they desire to do that, I definitely allow patients to split their dose up. I do try to push them away from multiple times a day dosing, maybe more than 3 times a day. At times patients will want to use Suboxone if they're feeling stressed or if they're in a fight or if they're having some sort of emotional response or something goes wrong in the day. They have a pattern of maybe going to use some sort of substance, and so I want to encourage them to get out of that pattern. Just take it at the same time, twice a day or once a day, to kind of encourage them to get out of that. So again, on how to take the medication, here's just a fancy chart that you can use. But the broad strokes on this are no eating, drinking, smoking for 30 minutes before you take the medication. That includes vaping as well. You're going to put the medication under your tongue, allow it to dissolve, hold it in your mouth for 20 to 30 minutes without talking or swallowing. That includes the saliva. After that, you may spit the medication out. It does not hurt you to swallow the medication, but recommend spitting it out. One-time rinse of your mouth at that point, and then an additional 30 to 30 minutes of no eating, drinking, smoking. There have been new things that have come out with Suboxone about how it's hard on your teeth, especially over a period of time, because you're just holding that medication in there, so it can cause issues with cavities and things like that. So there is recommendations of brushing your teeth an hour after you take the medication. For whatever reason, nicotine really does affect the absorption. I think it's due to the vasoconstriction that nicotine causes in the mouth, but I'll talk to patients who are on the medications. I can check the levels of the medications in their drug screen, and they're just saying like, "Oh, I'm just not feeling well." Their levels may be lower than what I would expect for their dose. And we talk about the smoking, and they're either smoking before or during dosing. And a lot of times when they cut that out, the levels of the medication significantly increase, and they feel a lot better. And again, just not eating, drinking, other things as well beforehand. So true or false, most patients should be educated to take their medication once a day. And the answer is true. That's sort of how the medication is designed, but we did talk about some reasons for not. All right, I want to spend a few minutes talking about precipitated withdrawals. So again, what is a precipitated withdrawal? Essentially, it's a condition when the opiate agonist, either methadone, heroin, fentanyl, is displaced from the opiate receptor by an antagonist, i.e. naltrexone or naloxone. This is what we want to happen when a patient is having an overdose. We want to give the Narcan, we want to displace that so that they wake up. Or it gets displaced by a high affinity partial agonist, aka Suboxone or buprenorphine, in an opiate dependent individual. So here's a picture of things we've talked about before, but this is the opiate receptor. Again, the opiate is on there. Suboxone gets introduced, it removes that opiate from there, and then we get this deficit in dopamine that happens really quickly and can throw people into precipitated withdrawals. So what are the signs and symptoms of precipitated withdrawal? Similar to those of spontaneous withdrawal, although much more severe. So I've had a handful of patients that I've actually seen that have been sort of in precipitated withdrawal. One of my patients, I was starting on Suboxone who was using fentanyl. We were using what we call a micro initiation, where we were giving very small amounts of Suboxone over the course of 5 to 7 days. Sent in the 2 milligram strips to the pharmacy. The pharmacy gave them the 8 milligram strips. So even though they were cutting those strips down and taking a piece, they were actually taking much more than we thought. This patient had taken a sort of like a 2 milligram, actually it was a half a strip, so it was a 4 milligram, and came into my office, and she was just miserable, right? Just couldn't sit still, just like nauseous, just very uncomfortable. When I talk to patients who have put themselves into precipitated withdrawal using sort of fentanyl or heroin or something on the street, all of them describe it as absolutely the worst experience. Like sometimes they go to the ER, although it's not necessarily life threatening, but it is just a very uncomfortable thing. And so a lot of times patients, if they've done this to themselves before, can be very scared to want to start Suboxone because they associate it with such a bad feeling. So again, the precipitated withdrawal usually happens maybe 30 to 90 minutes after the dose of the medication. It can last up to 24 or 48 hours. Here's a little diagram of sort of when this can take place and when patients feel really bad. If somebody does get themselves into precipitated withdrawals, it's hard to convince them, but actually what they generally need to do is take more Suboxone, because what has happened is the dopamine levels have dropped because of the blocking component, but we don't have enough buprenorphine on board to get the dopamine levels up to what their baseline was so that they feel normal. But a lot of times if patients can take an additional 8 or 16 milligrams of buprenorphine, that will actually help get them through the precipitated withdrawals. So again, we're available to consult if you have questions about that. And then again, here's just a quick knowledge check on this. What is the mechanism by which buprenorphine can precipitate withdrawals in an opiate-dependent patient? Sort of talked about this already, but again, it causes this displacement of the full agonist, rapidly decreasing the dopamine levels, which cause the withdrawals. If buprenorphine is new to you, one of the things you want to know about medications you're prescribing is what does it interact with, what's dangerous. When I talk to my patients, I say this over and over, but I would just say that the two things that are most dangerous with buprenorphine are alcohol and benzodiazepines. And so we do want patients to avoid the use of alcohol and illicit benzodiazepines. Again, there's been some studies that have shown adverse effects of oversedation, but highlighting here that the combination use of CNS depressants, although there's a risk of oversedation, the harm caused by not treating opiate use disorder can definitely outweigh those risks. So you may see patients that have other underlying substance use disorder. They may need a little bit more intense monitoring. And again, outpatient treatment is not necessarily appropriate for every individual. But generally, we want to stabilize the opiate use disorder, whether patients are using alcohol or benzodiazepines, because we're actually improving their safety profile. A quick example of that would be someone who's been abusing, let's say, Xanax, 3 milligrams on the street while they've also been taking oxycodone or heroin. I want to stabilize that opiate use disorder with the Suboxone because I'm actually improving their safety profile, even if they continue to take the same amount of benzos, because their body is used to both of those things at the same time. So a lot of times I feel comfortable stabilizing that and encouraging patients to cut back on their benzo use. And again, more frequent monitoring obviously would be necessary. Here's a fancy little sheet for you, list of benzodiazepines, different things, gabapentin, some muscle relaxers. The highlight here is just like, hey, the more things that you add, the more dangerous it can get for the patient, but also knowing that, like, if a patient has been on a certain combination of medications for a long period of time, their safety profile generally is better. The metabolism of buprenorphine, metabolized through the liver. So certain drugs that interfere with this pathway, HIV drugs, some antibiotics, antifungals, antihypertensives. This is really probably something I would pay most attention to on somebody on a lower dose of Suboxone, because if they take this on top of their lower dose Suboxone, and again, low dose for me is maybe 2 to 8 milligrams in the world that I live in, because they are going to feel maybe overly sedated from the medication, although probably not dangerous. But if a patient is on higher doses of medication, even if it's not leaving the system quite as fast, the ceiling effect is sort of going to be a helpful component for that. True or false, OUD patients with central nervous depressants are not candidates. Again, I just sort of repetitive here, but most patients should receive buprenorphine, maybe monitored more intently, even if they are using benzos. All right, I'm going to wrap it up here shortly. Here's a quick side effects of buprenorphine. The most common side effects I see in patients are headache and nausea. Other side effects that are maybe less common, peripheral edema does show up sometimes. Sometimes people are nauseated with the medication. The medicine does not taste great. It's actually pretty terrible. Patients say that they don't like the taste of it often. So safety precautions, again, we talked about this, stay away from alcohol and benzodiazepines. We always want to encourage patients, if we're prescribing Suboxone, to keep the medication stored in a safe place. Ideally, we like to keep that stored in a lockbox. I do recommend that you prescribe Narcan to all patients that are on Suboxone. Sort of the line that I say over and over every day is just like, hey, if a child or somebody who's never used opiates before, but mainly if a child got a hold of Suboxone, theoretically it could cause an overdose. And so we want you to have Narcan available. We want every adult in the house to know where the Narcan is and how to use it. If that would ever happen, give the Narcan and call 911 right away. Again, want to make sure that patients are aware of the dental concerns with it, and then obviously advising against the misuse or diversion of the medications. Knowledge check. What's the most common side effects? Again, headache and nausea generally are what we see most common. Sometimes encouraging patients to spit the medication out after it dissolves will reduce these side effects. Sometimes the side effects just get better with time as well. All right, so wrap up application in your daily practice. So again, buprenorphine, I would say, is the preferred agent in outpatient setting due to this safety profile that's safer, less risk. It works really well for patients. It allows greater flexibility, obviously, than methadone, and patients are able to kind of go on and live their lives normally where they're not interrupted quite as often. Nearly any patient with an opiate use disorder can be prescribed buprenorphine. There's multiple formulations of the medication that can help them. And then again, I would spend time with a new patient, just a little bit of time, either handing them a dosing form or just going over the proper dosing. The other thing that I just like commonly see in practice with someone who's brand new to Suboxone is initially they feel terrible and they're coming to you and they really want to get help and get better. And so they're really paying attention to the dosing of the medication for the first week or two. And then they come in like the third or the fourth week and they're just saying, the medicine doesn't feel like it's working as well. I'm kind of maybe getting some withdrawals. Maybe I'm having some cravings. And so Oftentimes I see patients who have just gotten lax in the dosing of the medication. And it's sort of interesting. I just equate it to like if you come to the doctor and you are feeling terrible with your sinus infection or whatever it is, and they give you a 10-day dose of antibiotics and they say, hey, take this whole 10 days of antibiotics. Well, when you feel terrible, you're taking it twice a day as need. I mean, every time. But then like once you start to feel better, it just goes into the back of your mind and you forget about it because you're busy with life. And so similarly with the Suboxone, just trying to be focused on the dosing correctly. It's not because people are trying not to do it. It just they're feeling better or they're feeling normal. The other thing is patients don't get immediate feedback from not dosing the medicine correctly because it is long acting. So sometimes it'll be a couple days later and they're starting to not feel as well. So again, just encouraging dosing is worth your time. I have in the PowerPoint here just some initiation options. I'm not going to go over those with you today, but they are available for you. I want to push pause here at this point and just kind of open it up for some questions. I do have one case study that I'm happy to go over with you that just sort of walks you through a general patient and some of the things that I do with them. But let me be quiet for a minute and just say, hey, if you got something in the chat or if you have questions, jump on and let's chat about that.
There's a question in the chat from Jill. What do you recommend for acute pain treatment, fracture appendicitis in the ER, post-op surgical pain, etc., for those who are on Suboxone?
It's a really great question. So we have a couple different options for patients, and John, you can jump into, but this is how we've managed it. Essentially, like let's say a patient is on 8 or 16 milligrams of Suboxone, I'll generally increase that dose to like 24 milligrams. I'll tell them that they can take that medication up to 3 times a day, and I'll do that for like a week. So my general thing for patients is just like, hey, if you're going in for an outpatient procedure, increasing your Suboxone and or splitting that dose for 7 to 10 days is generally going to work. I do not recommend patients stop their Suboxone prior to surgery. Again, with lower doses of Suboxone, there are other opiate receptors that are available in the brain. And so patients can actually continue their Suboxone, maybe even take an oxycodone or something on top of that for a short period of time, and then just continue their Suboxone. Or sometimes patients do prefer to stop the Suboxone, switch over to opiates, and then go back to the Suboxone. But a lot of times these patients, if they've really struggled with a substance use disorder, they don't want to get back on opiates. Now, if somebody's in the hospital, like the hospital will manage their pain, whether that's with Suboxone or IV fentanyl or whatever, and they can overcome the blockade of the Suboxone with that. So that's a really good question.
Yeah, that's the short answer to this is we're adjusting our thinking dramatically, where we don't precipitate withdrawal by classic opioids on top of buprenorphine as you would in the reverse. So if the buprenorphine is already on the receptor, then the acute care team really still has kind of carte blanche to do what they want. So in general, we're moving towards maintaining people on buprenorphine in the perioperative period. And that has led to a lot of confusion because we used to worry about that more than was necessary. But it's not as big a problem as we thought it would be, and patients do quite well with that. And it also, the only other thing I'd say is if you're going to switch somebody off of buprenorphine or have somebody be switched off for perioperative period, it's really important to communicate with the surgical team to say, all right, at what point are we going to reinitiate buprenorphine? Because that's always a point of destabilization. For several years ago, I had a long-term patient on buprenorphine that had a series of almost, inconsequential procedures. I kind of figured out she was just giving herself a drug holiday in order to kind of go back onto her Percocet and what have you. So once we stopped doing that, she ended up not having a bunch of little procedures that had probably not been necessary in the first place.
Got a question from Mark. We should talk about cost and how this affects uninsured or minorities.
Say that one more time. The cost. What was that?
It says, would you talk about cost? How does this affect uninsured and minorities?
Yeah, I mean, so a lot of the patient population that I treat, is on like a state insurance like Medicaid. So it does it does cover that pretty well. Obviously, self-pay can be more expensive. If you're talking about like medication wise for patients that don't have insurance that are just self-pay, you are going to get a lower cost with the monotherapy sort of Subutex. But again, the concern there is the risk for diversion of that medication. So yeah, there are some lower costs on the generic side of things, but generally covered pretty well under Medicaid or other insurances. The patients that you lose are the patients that like get their life back in order and then don't qualify for Medicaid again, and they're in this like gap of treatment. And so there have been some places where you can get like grants and things like that. I think I don't want to speak too much for things I don't fully understand, but I know there are some places out there that do help care for that gap population pretty well.
John had a comment that generic buprenorphine is similar in cost to equivalent opioid generic options. See a question from Scott. Could you comment on the use of off-label low-dose naltrexone up to 9 milligrams daily, and any safety concerns in patients who happen to take opioids while using low-dose naltrexone or upon low-dose naltrexone withdrawal?
Todd, I feel like that's your question.
What we're seeing kind of in the trend in low-dose naltrexone, we're creeping into full-dose naltrexone. We used to say low-dose naltrexone was 2.5 milligrams and below. If you recall, full-dose naltrexone is 50 milligrams daily. So I would say that as we get into the 9 milligram dosing and so forth, there may be potential for precipitating withdrawal. I really haven't seen it. I think that, you can be giving Subutex, and the low dose naltrexone is essentially like the naloxone portion of Suboxone. So it doesn't truly get in the way at that dosing. Although I correlate with 9 milligrams as low dose naltrexone.
Question from Kevin. Does the long half-lives of methadone and buprenorphine contribute to their ability to reduce addictive behavior? And if so, is it understood why?
It's a really good question. I would answer that with, I don't know. So when we talk about the long half-life, generally what I'm talking about is just like how long the medicine stays in their system before they start to go into withdrawals. I would describe it as like stable levels of buprenorphine allow time for the brain to heal, where we're not getting this up and down component, but just more of a steady dose. But that's my sort of off the cover. Todd, looks like you unmuted. Maybe you could.
Yeah, let me chime in on this, if it's okay. So first ask the question, what determines addictive potential? So let's start there, right? And what are the substances that are the most addictive? The ingredients that we know so far are related to route of administration, okay? So the faster a drug comes in, the more likely it's going to be addictive. Receptor occupancy is another ingredient. So the greater the number of receptors and the greater the potency is also a key ingredient. So those things that are injected and inhaled tend to be more addictive than oral routes of things. A medicine or a substance that comes in slower tends to be not always, but tends to be less addictive. So when you talk about addictive substances, right, things that people use IV or smoke, right, whether it's meth or cigarettes or what have you, tend to be more addictive. Now, let's talk about another thing that's really important here that we haven't covered today. And I say this because I worked in a methadone clinic a long period of time, and so I have a real comfort level with methadone. It's limited. Part of the limitation with methadone we haven't talked about is availability. It's only in Lincoln and Omaha, Nebraska. And so if somebody wants to be on it, they've got to drive. Federal regulation is likely going to become even more lax. It became more lax through COVID. And so we're probably going to see some change. Methadone can be prescribed for pain. And a lot of those people that have pain have addictions. So if you code it under pain, you're going to be okay if you use methadone. And the reason I'm bringing up methadone is not to kind of discount the effects of buprenorphine, not at all. The reason I'm bringing it up is potency of street drug use now for opioid use disorder is going up. Bup doesn't work as well. And so methadone works better, meaning for fentanyl, for somebody who is on fentanyl or using a lot of fentanyl, buprenorphine may work, it may help, but the higher the dose, the and the greater the potency of an opiate that someone's using, the less effective buprenorphine is. So keep that in mind, but also keep in mind that the methadone over time, the regulations may change. So hopefully that gets at some of the question, and I added a few other ingredients to the to the question as well.
I don't see any other questions in the chat right now. We've got 8 minutes. We could do a quick case. I know Ed's got a case. I think John's got a case on hand too. I don't, Ed, how do you want to do?
Yeah, I'm happy to. I can run through this in just a couple minutes.
Okay.
I'll share my screen here. Again, so this case is like, it's got a lot of hypotheticals. Obviously, it's not a real person, but I just want to like sort of walk you through quickly a patient that shows up in my clinic, what I'm going to do, what are some of the main things I'm going to think through in sort of the initial visit. So here's my patient presentation. 35-year-old female, comes to your office, 10-year history of opiate use disorder, started in her late teens recreationally. Sometimes it got started because of an injury or whatever, right? She was actually able to stop using opiates for several years. She had some kids, but then 5 years ago, she got a car accident, right? She was prescribed hydrocodone, has had some chronic pain. And then, she admits that she's been kind of overusing that and, using all of her script right away and then getting some from other people. Currently going through social issues. She's going through a divorce. She gets sick if she hasn't had opiates for 12 hours. Some days she can take up to maybe 10 pills a day. She's not been in treatment in the past. One of her friends told her about Suboxone, that it was helping her. So she wanted to come in and see if she could get some help. She's still dealing with the chronic pain. So she says her prescribing doctor, is either retiring or cutting her off or whatever. And so she doesn't know, what to do. So here's just like a quick thing of like the initial steps I take when I see a patient. One of the first things I always do is check the prescription monitoring program. Again, this gives me a little bit of data about the person that if I don't know them, of what prescriptions they've been on. And so we see in this patient, she's been getting prescriptions from her primary care doctor, but she also has some opiates from another provider periodically. Maybe that's ER or urgent care. And then she's also on the prescribed clonazepam. So again, just as I've quickly talked about this patient, you can already know that we can diagnose her with an opiate use disorder. She's been using it for a long time. She's overusing it. She gets withdrawals. She's had some tolerance. It's gotten in the way of some of her life issues. And so, again, it doesn't take a long time necessarily to diagnose someone based on just getting their story. And then I always want to know, like, hey, what's the patient's goals? Because I may have goals for a patient that are different than what theirs are. So she says her goals is to get off the opiates, to sort of get her life back. She wants to be able to take care of her kids. Again, she's still dealing with this chronic pain from this accident. She's concerned about not having something to help with the pain. So medical history, current medications, obviously you go through that like you normally would. No significant medical history. She's currently on an antidepressant. She does take clonazepam twice a day. We see that in the PDMP as well. I always like to ask about other substance use as well. So, hey, are there any other substances that have been problematic for you? For her, she says she's smoking, drinking some alcohol on the weekend. She doesn't overtake her clonazepam because she knows she's going to need it every day. She does use, marijuana, maybe recreational or periodically. And so wanting to know, like, hey, what other substances are we dealing with? Again, none of those things that she said makes me concerned about starting her on Suboxone in the initial treatment of the patient the first time I see her. So again, what treatment options are available? We talked about methadone as being an option if you're in the right city in Nebraska right now. Suboxone is what I'm trying to sell you on. Inpatient treatment is an option, maybe pain management, which can sometimes be hard to get into. Maybe this patient wants to go to detox, but also a difficult thing to get into on a short-term basis. And then again, just highlighting that, hey, naltrexone is probably not a good option. especially because the patient is actively using opiates and because the patient has chronic pain, they're actually going to benefit well from Suboxone. So what are the next steps? Okay, we know that we're going to start this patient on Suboxone. One of the things that I want to make sure that I do with the patient when I see them is sort of hit some of these high points. And again, I stole this little slide just from like what I put in my documentation when I see new patients. So I want to talk to them about Suboxone, give them a little bit of an idea of how it works. Want to talk to them about brushing their teeth afterwards, how to take the first dose of medication. So again, I'm going to recommend probably 24 hours of no opiate use. Start with a small piece of the Suboxone, maybe 2 to 4 milligrams, maybe even smaller than that. We're going to allow them to take that every 4 to 6 hours until they get their dose. If they start feeling overly sedated or sleepy, they can wait longer if they get into withdrawals. So like, again, just trying to like help patients understand, how am I going to get my medication? How am I going to start my medication? What things do I need to be concerned about initially? And then again, always highlighting like no benzos or alcohol, and then making sure that the medication is stored safely and prescribing the Narcan. This is just a quick, like, here's the prescriptions that I generally use, maybe sometimes in different amounts, but I prescribe Narcan, I prescribe hydroxyzine to help with withdrawals in the first 24 hours, Zofran, and clonidine as well. And then I'm going to give them usually a week's worth of medication of the Suboxone, because I'm going to want to see them back in the clinic within a week to see how things are going. Follow up, again, I mentioned this already, we're going to see them back in a week. If they're brand new, sometimes I'll see them more frequently than that. The concern I have of a brand new patient starting on Suboxone and just seeing them, 2 or 3 days after I start the medication, the medicine does take a little bit of time to like fully build up in the system, approximately 7 to 10 days. And so if I see a patient on Monday and they come back and see me on Thursday, sometimes they're like just sort of getting started on the medication and they may feel like the medicine isn't really working that well, but it's really hard for me to even know what adjustments to make at that time. Now, again, I'm happy to see them and kind of talk through and encourage them how to take it correctly. I oftentimes don't have a drug screen back in 3 or 4 days. And so I do like to have those results available when I see the patient the second time. We did not talk at all about drug screening, but there's going to be more to come in a couple of weeks. I think Stephanie's going to take us on a deep dive into that. So again, that's just like a quick little case study on a general patient. You can insert or take things away, but that's how I would generally approach that. And you can either ask some questions on that or we can call it a morning.
Any final questions? We've got about 2 minutes. While we're waiting, I put a link in the chat to the evaluation survey if you want to go and do that quick survey. And like I said, after doing the survey, your certificate's going to pop up automatically. And I'm also going to be emailing that survey out probably towards the end of this morning, so you can grab it that way too. Not seeing any questions. So hey, thanks, Ed. Great job today. And we hope to see you all back here in 2 weeks. We've got, let's see, Stephanie, Gail, and Ed talking about non-pharmacological treatment options for substance use disorders. Looking forward to that one. And good morning, everybody. Thanks.